So you've detailed the approval of 12 new agents for AML since around 2017, including menin inhibitors and CD123 target therapies. Which of these agents are most likely to reshape frontline therapy, do you think, or and for which molecular subgroup?
I mean, in AML, we have a lot of approval, and actually, I'm glad to see the menin inhibitors filling an unmet need. The FLT3 inhibitors, among others, IDH inhibitors, BCL2 inhibitors. However, I think the success is in the front line. The success is our capability to integrate these target agents into the front line. For example, today, if you look at the FLT3 ITD AML, where used to be a disease with a very poor outcome, if you integrate FLT3 inhibitors up front, if you go for transplant and you do maintenance post-transplant, you can improve the cure rate to 70, 80%, what historically used to be very low. The menin inhibitors, it's a horrible disease, but today, yes, they're effective in a relapse setting, but that is not what we want to accomplish. It's good, but we want to move this in combination of frontline to hopefully improve the outcome of these patients. Still, there's some work to go among them. For example, the MECOM AML, they do not do so well. The TP3 positive AML, these are we lacking. We need drugs for these patients, but I think overall we're making progress.
Mm. So when it comes to a triple therapy regimens in AML, what have intermittent interim results shown regarding efficacy and safety, and how close do you think we are to changing the standard of care for newly diagnosed or relapsed?
I give you an example of triple therapy is a FLT3 ITD AML, where we're using, for example, most of them are older unfit. We're using HMA as a backbone and venetoclax and adding FLT3 inhibitors. I think what we need to learn is how to manage these two drugs together because there's a price to pay for safety. That is still work in progress. I think we need to rely less on a venetoclax, be very anticipate change of dose and duration of therapy, but then having good testing to assess for MRD. And maybe, as we did in ALL, those who respond well and become MRD negative may not need a transplant to be done down the road. This is work in progress, and I think this is where we're heading. I think triplet is feasible, even quadruplet, but one should be very careful with the amount of drug given of each drug given in order to deliver a safe regimen.